Hello everyone. Today I'm going to present a topic which is related to infectious diseases. Today's topic is infective endocarditis. Let's learn in detail about this condition. So first of all, what is the definition? What exactly is infective endocarditis? So it is the infection of heart walls or the membrane lining the heart walls, and it also is an infection of the heart chambers because endocardium lines both heart walls and the heart chambers. Then the prevalence or epidemiology of this condition. So 2 to 15 cases are found per 1 lakh people, and the male to female ratio is 2:1. And there are two types of endocarditis, which is prosthetic endocarditis and native valve endocarditis. So the native valve endocarditis is approximately 71 to 78%, and prosthetic valve endocarditis is approximately 13 to 17% of the total cases. So the etiology or the causes, it mainly involves bacterial source, and the another cause is abnormal substrate. So in simple terms, one is bacterial cause and the other is any other causes which is not infective or directly related to pathogens. Out of the bacterial sources, the main causative organisms are Staphylococci, Streptococci, and Enterococci. So these three gram-positive microbes are the main reasons or the main bacterial sources which causes endocarditis. Gram-negative organisms are rarely known to cause endocarditis, but there are conditions where gram-negative organisms could be seen. And abnormal substrate includes rheumatic heart disease, then mitral valve disease. So if the patient has valve diseases, that could also cause endocarditis or lead to endocarditis upon further progression. Then aortic valve disease. So these two valves are the main valves that is mainly affected. And the tricuspid valve and semilunar valves are very rarely affected. And the pulmonary valve is also not affected mostly. So this was the normal introduction of this condition. This is an image where we can see the mitral valve and aortic valve. These two valves are the mainly affected valves, and the pulmonary valve and the tricuspid valve are very rarely affected. This could be due to the oxygenated part, since mitral valve and aortic valve are the more oxygenated areas or the areas where oxygenated blood is transported. So it is very ideal for the bacteria to grow near these valves. And this is the bacterial endocarditis where we can see a biofilm or a bacterial growth near the valves. There are certain risk factors that might cause endocarditis. So the risk factors are presence of a prosthetic valve. So if the patient has a prosthetic valve surgery or a prosthetic valve inserted, it might lead to bacterial growth. Previous endocarditis, if the patient has had a past endocarditis history, then it could also cause a latent endocarditis or relapse. Then healthcare related or exposure in healthcare settings. Then we have drug abusers or the IV drug users. They might share the needles or they might repeat the needle use and it might cause endocarditis in the patient. Then we have chronic heart failure, congenital heart disease, and as I mentioned earlier, mitral valve disease and aortic valve disease. Then chronic IV access. If a patient has chronic IV administration, then it might also lead to endocarditis. And sometimes fungi are also known to cause endocarditis, even though it is much rare or much less common than bacteria, but it could also be a factor. And then a cardiac implantation device. So these are the risk factors which can lead to endocarditis in patients. Let's learn in detail about the pathophysiology, or how is the endocarditis caused, or what are the details. So the first thing that happens is the endothelial surface of the heart is damaged. This could be due to a turbulent blood flow, which results in the damage of endothelial surface of the heart, and that is very ideal for bacterial growth. The second step that happens is the platelet and fibrin deposition occurs on the abnormal epithelial surface. So now, since the endothelial surface is damaged, the platelet and fibrin deposition occurs to heal this surface or to prevent blood flow, or to prevent the oozing out of blood. So it starts to deposit, but it sometimes results in excess deposition. And this deposition is known as sterile vegetation. And this condition would be known as non-bacterial endocarditis or non-bacterial thrombotic endocarditis. Then the bacteremia gives organisms access to the endocardial surface. So bacteremia is usually caused due to a trauma in the mucosal surface. This could be due to a dental procedure, a GI procedure, or a gynecological procedure. This leads to a trauma in the mucosal surface, which gives the organisms access to the endocardial surface, and then they start to form a vegetation. So after colonization of the endothelial surface, a vegetation of fibrin, platelets, and bacteria forms. So now, through the mucosal surface, the organisms got access to the endocardial surface via blood, and then it starts to form a vegetation, which is a mixture of platelet, fibrin, and bacteria forms. So these fibrin and platelets form a shield for the bacteria. It protects the bacteria from the host immune, and thus the bacteria can form a biofilm. And the bacteria is not affected by the host immune responses, since this vegetation of the fibrin, platelets, and the bacteria forms is very much matured, and it is protected by this layer. So now the bacteria starts to form a biofilm, and it is very hard for the body to fight against this causative organism. So let's learn about the clinical presentations, or how to identify whether a patient has endocarditis or not. So there are multiple non-specific clinical presentations in a patient. So the first non-specific clinical presentation is fever, which appears in approximately 90% of the patients. The second is heart murmur, and it appears in approximately 85% of the patients. Then we can see night sweats, dyspnea, and chills. Weight loss is also seen in some of the patients. These are the clinical presentations that we can see in a patient who's suffering from infective endocarditis. Other peripheral clinical presentations seen in this patient are: this is a splinter hemorrhage. So this is linear hemorrhages that forms under the nail beds, as we can see here. These are hemorrhagic linear forms that forms under the nail beds, and this is called as Janeway lesions. These are also non-painless hemorrhagic erythematous forms that forms near the palms and in the soles of feet. Then this is osler node. This is more specific, and it is usually near the fingers or tips of the fingers and toes, and it is painful, whereas Janeway lesions are not painful, they are painless. A rod spot which is formed in the eye, and this is a petake. These are also erythematous papules or nodules that are formed in the skin, on the skin. So diagnosis, there is a diagnostic technique called the Duke's criteria. For the Duke's criteria, there are certain criteria termed under major criteria and minor criteria. For major criteria, blood culture positive for infective endocarditis. So if there is a positive blood culture, it falls under the major criteria. And these involve typical microorganisms consistent with infective endocarditis from two separate blood cultures, and at least two positive blood cultures drawn greater than 12 hours apart, or three or a majority of four or more separate blood cultures with first and last sample drawn at least 1 hour apart. So these blood culture fall under the major criteria. And then evidence of endocardial involvement. We need to know whether the endocardium is involved or not. For that, echocardiogram positive for infective endocarditis. And there are types of echocardiogram, which is transesophageal echocardiography and transthoracic echocardiography. So it is recommended for patients with prosthetic valves, then oscillating intracardiac mass on valve or supporting structures, new partial dehiscence of prosthetic valve, or new valvular regurgitation. Then the minor criteria involves predisposing heart condition or injection drug use, fever and temperature. These are non-specific clinical presentations. Hence, it falls under the minor criteria. Any vascular phenomena, any immunologic phenomena like glomerulonephritis, Osler's nodes, then a microbiologic evidence, which is again a positive blood culture, but does not meet a major criteria as noted above, or serologic evidence of active infection. Then a echocardiographic minor criteria eliminated. And HACEK, these are the causative organisms, but they are not the main causes, which involves Haemophilus species, Aggregatibacter species, Cardiobacterium hominis, Echinella corrodens, and Kingella kingae. So according to those major and minor criteria, definitive infective endocarditis is determined by a pathologic criteria, which is microorganisms demonstrated by culture or histologic examination of a vegetation that has embolized, or an intracardiac abscess specimen or pathologic lesions. Then the clinical criteria involves two major criteria or one major criteria and three minor criteria. So either it should be two major. If we have two major criteria, we can say that the patient has definitive infective carditis, or else one major criteria and three minor criteria, or else we need five minor criteria. So any one of these criteria, if it is fulfilled, then we can say that the patient has a definite infective endocarditis. For possible infective endocarditis, one major criteria and one minor criteria, or three minor criteria. And for a rejected infective endocarditis, firm alternative diagnosis explaining evidence of infective endocarditis, or resolution of infective endocarditis syndrome with antimicrobial therapy for 4 or fewer days, or no pathologic evidence of infective endocarditis at surgery or autopsy with antimicrobial therapy for 4 or fewer days, or which does not meet criteria for possible infective endocarditis as above. So if any of these conditions are seen in a patient, then we can say that the patient is not suffering from infective endocarditis, or it is rejected infective endocarditis. So these are the treatment recommendations. These are the dosing. So let's learn about treatment options. First, for native valve endocarditis by causative organism. This is from a standard textbook, which is by Joseph T. DiPiro. These are the pharmacologic agents used in native valve endocarditis for highly penicillin susceptible organisms, which is Streptococci and Galolyticus. Aqueous crystalline penicillin is used for 4 weeks, and 2 week regimens are not intended for the following patients: patients above 65 years, children, and patients with impairment of the eighth cranial nerve function, renal function with a creatinine clearance less than 20 ml per minute, known cardiac or extracardiac abscess, and infection with Abutrophia, granulosatella, or Gemala species. We have ceftriaxone for 4 weeks, aqueous crystalline penicillin G sodium plus gentamicin for 2 weeks, ceftriaxone plus gentamicin and vancomycin for 2 weeks and 4 weeks respectively. Then for Viridans group Streptococci and S. galolyticus, relatively resistant to penicillin, Patient could be administered aqueous crystalline penicillin G plus gentamicin, ceftriaxone plus gentamicin, and vancomycin, which is recommended only for patients unable to tolerate penicillin or ceftriaxone. Then oxacillin susceptible staphylococci, nafcillin or oxacillin, cefazolin for use in patients with non-anaphylactoid type penicillin allergies. Patients with an unclear history of immediate type hypersensitivity to penicillin should be considered for skin testing. Other drugs involve vancomycin and daptomycin for 6 weeks. Then oxacillin-resistant staphylococci, vancomycin and daptomycin could be administered for 6 weeks in these patients. The second type is treatment options for prosthetic valve endocarditis by causative organism. So again, we have highly penicillin susceptible viridans group streptococci and S. galolyticus. For this, we can administer aqueous crystalline penicillin G sodium with or without gentamicin for 6 weeks to 2 weeks, ceftriaxone with or without gentamicin, and vancomycin for 6 weeks. Relatively resistant or fully resistant viridans group streptococci and S. galolyticus. Aqueous crystalline penicillin G sodium plus gentamicin, ceftriaxone plus gentamicin, and vancomycin. For oxacillin susceptible staphylococci in prosthetic valve endocarditis, we have nafcillin or oxacillin plus rifampin plus gentamicin and vancomycin plus rifampin plus gentamicin for more than 6 weeks. For oxacillin-resistant staphylococci, we have vancomycin for more than 6 weeks, plus rifampin and plus gentamicin. The next are the treatment options for native or prosthetic valve endocarditis caused by enterococci. The previous treatment options were mainly for streptococci and staphylococci. These are the treatment options for enterococci. So the agents used are ampicillin plus gentamicin for 4 to 6 weeks, aqueous crystalline penicillin G sodium plus gentamicin for 4 to 6 weeks, ampicillin plus ceftriaxone for 6 weeks, and vancomycin plus gentamicin for 6 weeks. For gentamicin-resistant strains, if susceptible, use streptomycin in place of gentamicin. If creatinine clearance is more than 50 ml per minute, and if cranial nerve 8 function is intact and there is laboratory capability for rapid streptomycin serum concentrations. For penicillin-resistant strains, ampicillin sulbactam plus gentamicin for 6 weeks, vancomycin plus gentamicin for 6 weeks. May also use in patients with beta-lactamase producing strains who have known intolerance to ampicillin sulbactam combination. So vancomycin plus gentamicin would be a great choice in patients which have beta-lactamase producing strains. Enterococcus faecium strains resistant to penicillin, aminoglycosides, and vancomycin. In this case, we can use linezolid for more than 6 weeks and daptomycin for more than 6 weeks. The next is treatment options for culture-negative endocarditis and endocarditis caused by gram-negative organisms. So the HACEK microorganisms that we saw earlier, for these microbes, we can use ceftriaxone for 4 weeks, ampicillin or ampicillin sulbactam for 4 weeks, ciprofloxacin for 4 weeks. Culture-negative endocarditis or native valve endocarditis. So culture-negative endocarditis is where no pathogen is seen in the blood culture, but all the other parameters for endocarditis are fulfilled. So in this condition, vancomycin plus cefepime for 4 to 6 weeks and vancomycin plus ampicillin sulbactam for the same duration could be administered. Culture-negative endocarditis, early prosthetic valve, less than 1 year. Vancomycin plus cefepime plus rifampin plus gentamicin for 6 weeks. And culture-negative endocarditis, late, which is more than 1 year, prosthetic valve, vancomycin plus ceftriaxone for 6 weeks. Suspected Bartonella culture negative, ceftriaxone 6 weeks plus gentamicin 2 weeks with or without doxycycline 6 weeks. And for culture positive Bartonella, doxycycline plus gentamicin for 6 weeks and 2 weeks. Let's learn about the dosing of these agents. Firstly, ampicillin, 2 gram IV every 4 hours is the recommended dose, and for pediatric dose, it is 50 mg per kg every 4 hours or 75 mg per kg every 6 hours. Ampicillin sulbactam combination, 3 gram IV every 6 hours, and pediatric dose is 50 mg per kg every 4 hours or 75 mg per kg every 6 hours. Then cefazolin, 2 gram IV every 8 hours, 33 mg per kg IV every 8 hours is the pediatric dose. Cefepime, 2 gram IV every 8 hours, and pediatric dose is 50 mg per kg IV every 8 hours. Ceftriaxone sodium, 2 gram IV or IM every 24 hours, and pediatric dose is 100 mg per kg IV or IM every 24 hours. Other agents are ciprofloxacin, 400 mg IV every 12 hours or 500 mg per oral every 12 hours. And pediatric dose is 20 to 30 mg per kg IV or per oral every 12 hours. Daptomycin, more than or equal to 8 mg per kg IV every 24 hours, and pediatric dose is 6 mg per kg IV every 24 hours. Doxycycline, 100 mg IV or per oral every 12 hours, and pediatric dose is 1 to 2 mg per kg IV or per oral every 12 hours. Gentamicin sulfate is 3 mg per kg IV or IM every 24 hours or 1 mg per kg IV or IM every 8 hours. SC. Then pediatric dose is 1 mg per kg IV or IM every 8 hours. Linezolid 600 mg IV or per oral every 12 hours, and for pediatrics 10 mg per kg IV every 8 hours. Nafcillin or oxacillin 2 gram IV every 4 hours and 50 mg per kg IV every 6 hours in pediatrics. Rifampin 300 mg IV or per oral every 8 hours and 5 to 7 mg per kg IV or per oral every 8 hours in pediatrics. Streptomycin 7.5 mg per kg IV or IM every 12 hours, and vancomycin is 15 to 20 mg per kg IV every 8 hours or every 12 hours, and in pediatrics 15 mg per kg IV every 6 hours. So these were the treatment for particular causative organisms and the dosings for all these agents. So that's it for today's session. Thank you for watching, and please share this video.